Thank you very much, Gail. Our most recent encounter was when we jointly were engaged in a rather lively forum on wind turbines. And on the basis of that very energetic meeting, I can tell you I have a great admiration for Gail as a chair, and I'm quite fearsome of her ability to control that audience. I'm about to talk about the Research Translation Faculty, which is a new innovation at the NHMRC. We're working with what is known as a virtuous circle, and in our case the virtuous circle, because it's the one that applies to us, which came through, I think, initially in the Wills Report. For those of you who are old like me, you can remember the Wills Report. And this is about research leading to outcomes that benefit Australia. So there's research, which is the bright end of it, which is shiny and everything's possible when you're doing the research, which is some of the wonderful things we heard about this morning. And then there's getting that to make Australians healthier, to get better treatments in hospitals, to get better public health policy, improved healthcare and wealth generation, which is also an important part of what we do. I'm going to be talking, I think, around this end. Some of the things we're talking about are around the far end, which is where things are really getting closer to practice. So let me tell you what I'm talking about. First of all, translation of all the research we do benefits many. If you don't think translation's important, you need to sit in camp around budget time when everybody wants to know what value they're getting for the public money that goes into it, and public monies in research is substantial. One of these comes from our colleague in Canada, Jonathan Lomas, who's a great supporter of prevention and of the agency. I've just gone back, I think, by mistake. So there's a balloon floating along which people say, "Where am I?" And you're 30 metres above the ground in a balloon. You must be a researcher. How did you know? Because you told me what is absolutely correct but completely useless. You must be a policymaker. Yeah, how did you know? Because you don't know where you are, you don't know where you're going, and you don't know, and you're blaming me for that. So, thank you, Jonathan. So, number of the difficulties, there are lots of difficulties about translation, moving from that bright, shiny research into practice. The first barrier is the one we've just demonstrated there, which is the different views on this from the professional scientific expert community, where the strong line is always to objective indicators or systematically reviewed indicators and so on, whereas the layperson is more focused on the experience, the important things in their world and so on. So there's quite a different view, and quite often the two can be aligned by moving upstream to do it, but sometimes they just are different and it's hard to do. The next barrier is that translation is slow. This is some work that Larry Green presented at our Translation Faculty Symposium last year. I've cut out a bit of the kind of references and timing things, but there's original research going through submissions, acceptances, publications, bibliographic databases, getting into that unless it gets lost or the indexing is wrong and you can't find it, reviews of guidelines, etc., and then into implementation. So there's a long process from that work that you're doing through to something getting into practice. It takes, on that estimate, based on the evidence that Larry put together, 17 years to turn 14% of original research into healthcare benefit of some kind. So it's a long process. The good thing is that we're often up here when we actually need to know something, so we can actually pull it out of the literature. But it can also be worse. Things can go a bit slower, actually. So that's one of the hard parts. Third barrier is that it does actually require a good system to take it through that sort of pipeline. Marcel Tenner at the Swiss Tropical Public Health Institute, he's the director of it, looked at a vaccine that was highly effective, so 80% effective, and then you get 80% access to it, which is actually, these are not bad numbers actually. Targeting accuracy of 80%, provider compliance of 75%, which is excellent. Consumer adherence was 75%, and then under that best kind of case, you've got 29% effectiveness of what you're doing. So that's in a good system. So there's lots of system things, including the people and the teams who do it. Would you like to do research translation with Dr. House? Robert Wackman, the chair of the American Board of Internal Medicine, when the House program was shut down, there was outcries all over the US media saying, bring it back, it's a wonderful program. And his comment to the media was, we need practitioners who are smart, well-trained, innovative, intensely focused on delivering the best care, and who can play well with others. While House had many of these skills, the teamwork part of it was a fatal flaw. If he worked with me, I would have fired him. So rest in peace, Dr. House. So that's another side of this. Is very much people-driven, and I'm sure those of you who are at the hard end of this really understand that part of it. To get a better part of this, and I should add that this is the first requirements under the Act of the CEO of the NHMRC, which is to issue guidelines and to provide advice and information to the public on what's going on in health. So we've established just in October last year a research translation faculty. So we're trying to map that in key outcomes, so new translation opportunities to bring some innovation, some ideas and some fresh energy into the system, so that we develop ourselves more as an innovative health system contributor in research translation, not just in research, but in research translation, to create a productive faculty member community. I'll talk a little bit more about that community in just a minute, and to have an effective and efficient translation capability, so there's a better engine underlying this. Coming back to this, the community we're talking about are the people who are funded by NHMRC. It's targeted around 4,000 and 2,600 have voluntarily accepted to be part of this faculty, and that's the member community, and we're trying to turn that into a translational group, and I'll talk a little bit more about what we're doing there. And that's why I said in that virtuous circle we were more tighter at the research end than at the implementation doing end of it. So we're a little bit upstream. There's still quite a bit of work to be done while we're doing ours. So what we're asking people to do is to identify evidence gaps, and I note there are actually some members of reference groups for the faculty in the audience. So you could call for a development of a guideline. So we know the evidence, but nobody's doing anything about it. You could publish an evidence summary. That is, the evidence is there, but it's never been put together to say what it really says. You could get the NHMRC through the Council and CEO to make a public statement that something should be happening. So this could be, for example, a statement on fluoride, which we have done in the recent past. You could advise the health ministers about health policy to say this policy isn't working in the view of the evidence we have. Work with other agencies, including universities if we needed to. And the last one on the list is specific and targeted further research. It's last on the list because we're trying to translate existing research. It would only be the case where there's a significant missing link that would really produce something of value, that this comes into play. So the research side of it is well dealt with at the other part of what NHMRC does. So these are assessed on the priorities against the strategic plan and national health priorities. The significance, whether it really does make a difference in terms of covering that evidence practice gap, and the approach. That's the sort of things you would expect in a good proposal. I won't deal with that, and that's not relevant now. So the major health issues are those from the national health priorities. I don't think I need to read those, but they're the key ones that have been nominated nationally as our national health priorities. And then added to those are 8 other priority areas that NHMRC has in its strategic plan. So we accept whole bolus, the national health priorities. And then we have a priority to improve the health of Aboriginal and Torres Strait Islanders, preparing Australia for the omics or genomics revolution in healthcare, primary healthcare, improving the care of patients with multiple and complex chronic diseases, a healthy start for a healthy life, claiming benefits for human health that are not based on evidence, and that covers a range of things, new and emerging health threats, of which there are a lot, and health and research in our region. So around those 17 areas, we have reference groups formed. As I said, some of the audience are members of those. So a steering group is already active on all those themes, from a couple which are going to be developed later in conjunction. So research in our region will be done jointly with people like AusAid and others, and that will be developed there. So the steering group priorities come through various committees. In particular, the Prevention and Community Health Committee would be receiving those with a health services public health focus. And then they go through a process where they would get to council to be approved and through to the CEO for the whatever the action is that's required. So it's a broad spectrum of possibilities of cases for action that we're calling for. So it will give a sense of lots of life and activity and colour. So that's where we're at, and I thought I just might finish off by saying that we would have hoped that we had a glorious bridge. By the way, I stole this from Francis Collins, who came out here to talk. He's the head of the US National Institutes of Health. So we would have hoped that we had, from our fundamental research knowledge, the applications of it. However, there are very different ways of getting across, some of which we've talked about in my talk. So they always get hit by clouds, so you have sharks in the water, and what happens over time is that you lose the swimmer, you lose the sailing boat, you lose the motorboat, and it's the rowboat that's at the end that we get across. So we're not pessimistic but realistic about what we're doing in research translation. Thank you.
Well, thank you for giving me a chance to talk this afternoon. I'd like to acknowledge the traditional owners of on the land on which we're gathered today. John McCallum and I go back a long way. We're great friends, and we've also spent a lot of time talking about many things in our lives, but we were just chatting before, and we decided our greatest achievement was that John built the University of Western Sydney Anatomy School, and I accredited it, which was the first new anatomy lab in New South Wales for 25 years. So it sort of brings you back to the sort of basics of healthcare. I'm going to talk today a little bit about the new NHMRC Partnership Centre on Systems Perspectives on Preventing Lifestyle-Related Chronic Health Problems. And we're offering a prize for anybody who can come up with a shorter title for us in relation to that. I acknowledge the other people who have been heavily involved in the planning of this. It's, as you'll see as I go through, it's a large partnership in terms of the people that are involved in it, and many of them are in the room today reflecting this group of people that we've got involved in this. The partnership centres were envisaged in terms of what they were aiming to do is to bring together teams of researchers and decision makers together to work collaboratively on issues determined by the needs of the health and healthcare systems. They're jointly supported by the NHMRC and organisations in terms of their funding, and they're going to particularly have a focus on research-informed change in practice, management or policy as one of their sort of driving activities. We've been through a long process in getting to where we are. This process started at the beginning of last year and it's yet complete, as Warwick indicated this morning. We're still awaiting for the ministerial announcement about it, but we're pushing ahead to try and finalise some of the contracts that we have. The Partnership Centre, so in fact we're at the moment not just a virtual centre, we're actually virtually still waiting to be announced and to become existent. And in the current political environment, you can imagine that I wake up most mornings and check the headlines quickly to see what's happening. The Partnership Centre will undertake an integrated program of work designed to enable policy and program developers to make better decisions about the strategies and structures to prevent lifestyle-related chronic conditions. It will build information and actions required to establish population-wide and efficient and effective preventive health system, establish frameworks and capacities to assist government decisions about investment in prevention, and enable the assessment of population cost effectiveness of potential investments in prevention interventions. Now, that's an extraordinary range of things that we're being asked to do, and an extraordinary breadth of things that could potentially be incorporated within that. I thought Elizabeth's presentation this morning and gave you a sense of just one small area when she talked about obesity, of the breadth of things which can happen when you think about the types of systems perspectives that might bring to it. And then when you take that sort of research and you put it into the real world and you think about Shelley Bowen's presentation about what's happening in Victoria, you can see that there's an extraordinary scope of activities that we could potentially be involved in. And a large part of what we've been involved in the last 12 months is trying to resolve those areas where we're likely to make some of the biggest impacts in relation to this, driven by the priorities which are set by our funders. So the Partnership Centre, the funding partners for us for the centre consists of the two largest funders, which are the NHMRC and the Australian National Preventive Health Agency, the New South Wales Ministry of Health, ACT Health, and the HCF Foundation. There's a large number of people involved in it from the universities. There's some 8 universities or research institutes that are partners in the organisation. We're spread across New South Wales, ACT, Victoria, Queensland and the Northern Territory. And we have an important part of the partnership centres is the bringing together of people, but not from the research community, with what are used in the partnership terminology are called system investigators. And we have some 14 investigators at this point in time from a range of government agencies, not just in health, but from Treasury, transport, major infrastructure. We have one of the private consulting companies in architecture, but particularly interested in built environment involved in it. We have private sector partners, and we also have the National Heart Foundation and the Cancer Council Australia involved in this project. So it's a very large partnership seeking to bring together a lot of the expertise that's there. One of the things that has been very interesting for me today in listening to many of the presentations is that it just reminded me of the extraordinary diversity and depth of things which are already occurring in Australia. And when I talk about the role of the centre in the synthesis of information, we tend to think about synthesis in a very narrow focus. We tend to think about synthesis as being those sort of systematic reviews, meta-analysis, that type of thing as the synthesis of data. And in the strictest sense of the word, that's what it is. But for me, the role of the centre is very much about looking much more broadly at the information that can inform practice and policy in this sphere. It's bringing together both that information which has been systematically gathered, which has been researched, with the real-life experience, the learned experience of practice, of what happens in practice. And that's what Shelley Bowen was describing this morning, that active learning process, that we will be working in extremely complex environments, ones where it's even difficult to impose a logic framework around it, one where there is a constant shifting of the different components. And we're going to have to be flexible, and we're going to have to change our priorities to reflect the fact that multiple things are happening. We shouldn't see that as a negative thing. It's a very positive. It's an aspect of Australia that we should be very proud of. What I think is one of the great benefits that ANFA has managed to bring to this area is to actually have a national leadership around the whole prevention strategy. It's actually got us starting to think about what we're doing and the different elements and how we bring them together. And the centre will help to do that in a more systematic way. I don't want to spend a lot of time talking about the structure of it, of the organisation, but broadly it looks a bit like this at the moment. We have our first 2-day planning session on Monday, Monday and Tuesday of next week. We're bravely assuming that life will go on, regardless of what the politics or what happens in the political sphere at this point in time. The centre is administered through the Sachs Institute, which I'm sure most of you are aware of. And I report through to Sally Redmond there as the CEO of the Sachs Institute. But the governance of this is through this funders committee, which consists of the funders of the organisation, who will have some very major expectations and who will keep us on track, which is unlike a program grant, for example, where in fact the researchers get on and do their work. We will have this very close oversight and ongoing expectations from this funder committee. It's complex when you try and bring these things together, and it's complex to try and capture it in some sort of diagrammatic way. I've got just a couple of pictures here to try and give a sense of how these things will actually be drawn together in terms of what we have there. So we see this as having many dimensions. Here we've drawn them as 3 in terms of this. It's very much working in that space around implementation. So you'll see in that top green top green block there a reference to exchange forums and what we call implementation forums, which will be convened around researchers and industry partners and people who want to participate this to create learning situations to actually take real life experience and say, okay, well, what do we actually learn from that? We might not have documented it, we may not have evaluated it, but what did we actually learn from that, and how do we then incorporate that with the things that we know about in a more formal way? So broadly, we will have these 3 objectives: to strengthen the research base for prevention, to synthesise evidence with that broad definition of synthesis that I talked about, and make readily available what is known, and that we will help activate an effective and efficient prevention system so that we know and we can say to government and funders that we actually used the funds that we get in the best ways that we can. And from that, we hope we'll get a greater appreciation of the value of prevention among government agencies and the community. We'll develop some tools and systems and methods to underpin that national prevention system. We'll be aiming, of course, for an international standard of new research in the prevention of chronic disease, although that's not our primary focus. We'll be looking to develop new partnerships, collaborations that will persist beyond the 5-year life of the centre, and we'll be looking to develop those new methods for researchers and policy and program practitioners to work together. And we have a very significant part of our investment is in increasing people capacity both in terms of the research skills, but we also, for example, have a program which will focus on the issues of communication, of, for example, working with groups like Public Media Interest Centre and groups like that about how we communicate the prevention message. To just give you a sense in closing that this is a very much a multi-pronged program that we've put forward. There are many different elements to it. Just in the first year, there are some 29 projects which are proposed as part of what we're trying to do, but they are all mapped and fit together. So here's just an example of how we sort of will fit together some of these different components of what we're trying to do. So around this idea of a great appreciation of the value of prevention among governments and community, we'll be doing work looking at a better understanding of the economic value of prevention, and you'll see some of the early work of that in a paper which will come out on the, is that part of the launch in August? July. And the State of Prevention report, which ANFA will release at that, you'll see some of the initial thinking around some of the better understanding of the economic value of prevention. We've talked about the synthesis of available information about the value of prevention, above a broader message about that we're not going to repeat meta-analyses and reviews, etc., that we will draw on that work, that's much of which is already being done by some very competent people in Australia. Elizabeth didn't give her excellent meta-analysis that she's done on obesity control in childhood, but that sort of thing, but we will add to it and add value to that by bringing to it the understanding of the practice elements. We're looking at engagement of the non-health sectors through the implementation exchanges and through our team. We're looking about how we can communicate that better, thinking very closely about the sorts of things that will lead to both messages, both for the community, but also for decision makers in relation to that. We're looking at what we've called training of health journalists here. That's a bit pretentious the way that's put forward, but working with some of these agencies to look at how we communicate broadly to the community and about those values. So whole streams of things that will link together around this. So as I say, we're still in a holding pattern at the moment. We're getting closer and closer to takeoff, we hope. And I look forward to working with the research and practice community in Australia in building a stronger prevention capacity in our country. Thank you very much.